Hello, everyone, and welcome to the very first episode of Acute on Chronic podcast, your source for learning how to navigate the American healthcare system and be empowered as your own best health advocate. I'm your host, Dr. Olivia Rivera, a psychiatrist in training with a background in law and public health, and together we're going to demystify how our healthcare system really works. Before we begin, a little bit about why I made this podcast. In today's world, there is constant information overload. Social media, misinformation, disinformation, all fighting for our very limited attention. I thought for a long time before launching this show if I really wanted to add to this information economy, add to all this noise. But what I'm realizing in 2025 is that there really aren't enough sources that combine good information, grounded in evidence and facts, with good vibes. Am I right? There are some good information sources that I trust for the facts, but they leave me depressed every time. And there are some feel-good sources that I use for the vibes, but the information is a little light on facts and evidence. I'm hoping this will be a place where we can both have a good time and learn some important tools for optimizing our health and navigating the very complex American healthcare system. I come from a community where lack of access to care is a huge issue. And it stems from things like lack of finances, lack of physical access, even distrust of medical institutions. Knowledge is power, and there are things that we can do to empower ourselves. This season, we're going to tackle some big topics, from breaking down health insurance jargons, to the problems in our ERs and urgent cares, to the correct way to ask healthcare questions on the internet, and even how to navigate the referral process. By the end, we should all feel a little more confident advocating for our own health. Today, we're going to talk about something that, on the surface, may seem purely behind the scenes, but absolutely affects your health experience. Physician compensation. How do doctors get paid? Who decides what they earn? And how does that payment structure impact the care you receive? Grab your coffee, get comfortable, and let's dive in. Have you ever wondered if the way your doctor is getting paid impacts the quality of care you're receiving? If so, you're not alone. At heart, healthcare is a customer service industry. For some doctors, the number of patients they're able to see in a day directly impacts how much money they pocket. For others, they save money and therefore gain profit by minimizing the number of tests or procedures that they order for patients. And for more still, there's not much relation at all between how they provide care and how they get paid. Each of these models have different implications for patients. So today, we'll dive into the different models of compensation for providers, the advocacy effort towards models that value quality over quantity, and how you can advocate for yourself the next time you're in a doctor's office.
It's an unbelievably complex subject. Nobody knew that healthcare could be so complicated.
This is more than just about healthcare. It's about the character of our country. It's about whether we look out for one another. It's about whether the wealthiest nation on earth is going to make sure that nobody suffers.
Today, we'll cover 4 models of compensation: fee-for-service, salary-based, capitation, and value-based. And if your eyes are already glazing over, don't worry. We doctors love our big words, but I'm going to break it down in pretty simple terms. Let's start with the fee-for-service model, sometimes also called a productivity model. For much of the 20th century, this was the most common compensation model for physicians. Under fee-for-service, physicians are paid for each service or procedure they perform. Think office visits, lab tests, imaging, surgeries, all of it. Fee-for-service started as a way to reimburse providers for everything that they actually do. In theory, it's straightforward. Do a test, get paid for that test. Perform a procedure, get paid for the procedure. However, this model raised concerns from patients that physicians had incentives to order more tests or procedures than necessary. If your doctor only gets paid when they do something, there might be a motivation, conscious or not, to do more. Fee-for-service can sometimes lead to amazing thoroughness, but it can also lead to cost inflation. And because many patients don't see the bill directly, especially if insurance picks up the tab, they may not even realize a test wasn't essential. In reality, this concern was probably overblown. While there are always a few bad apples in the bunch, there's little evidence that this model really changed how clinicians practice. However, as more and more providers transitioned from working out of small private practices to working in larger group practices and hospital-associated clinics, this model lost supremacy. Rising up to take its place as the most common compensation model in the 21st century, the salary model. This is often seen in academic hospitals, large group practices, or health systems. In this model, a physician has a fixed annual income, sometimes with bonuses for productivity or quality measures. A salary model makes sense for large practices, as it can help with stability and predictability both for the doctor and the institution. The physician doesn't have to worry about not having sufficient income during periods with low healthcare utilization, such as the summer, where people frequently travel and schedule fewer doctor visits. It also provides stability for the hospital system, knowing exactly how much it will be paying out in salary expenses month over month. There was also the thought that salary models benefit patients by reducing the perceived pressure to do more simply to earn more. Now, I really do want to reiterate. For the most part, physicians are a deeply caring bunch of people who do this work for the love. And we all take oaths, and most of us take them very seriously. However, even the perception of perverse incentives erodes institutional trust, and salary models were one way to overcome that. Another benefit to the salary model was the thought that physicians might take extra time with each patient, knowing their paychecks don't hinge on the volume of tests or procedures that they're doing. Now, it turns out that strength can also be a weakness. Critics of the salary model note that if there's no incentive structure, there may not be sufficient guardrails against underproduction. Employers of physicians especially were worried that this kind of model might not inspire their physicians to go the extra mile in terms of making money for the hospital. And that makes sense. If I'm getting paid the same either way, I'd rather take an hour with each patient and only see 8 to 10 patients each day rather than a half hour or 20 minutes to see double the number of patients. And considering America's looming physician shortage and long wait times, it's not necessarily better for patients if physicians are seeing fewer folk and having longer visits. So was born the bonus system. In this model, you get your base salary, and if you hit certain metrics by the end of the year, you get a little extra, usually around 10% or so of your annual salary. These metrics could be seeing a certain number of patients or generating a certain amount of revenue. And it motivates providers to be thinking not just about excellent patient care, but also about efficiency and revenue. I think a lot of people feel like this is a nice middle ground between straight salary and fee-for-service. There's some incentive for efficiency, but the most you can make in a year is an additional 10%. So there's less worry that a provider might be throwing lab tests at everyone, Oprah style, saying, you get a CBC, you get a CBC, you get a CBC. But I digress. That's pretty much the highlight of the salary model. For our more advanced listeners, the salary model also includes the minimum income guarantee, but we're not going to be talking about that in this episode. So just consider it another type of salary employee. Now, our third model to discuss is capitation. This is a system where a doctor or medical group is paid a set amount per patient they care for, regardless of how many services that patient uses. For example, a practice might get X dollars per member per month from an insurance company, covering all medical costs for the group of patients who use that insurer. This model gained traction with the rise of managed care in the 1990s. Think HMOs. And if you don't know what any of that means, keep an eye out for our health insurance episode. We'll break down all that jargon. For now, think of managed care as a health insurance that provides prepaid health plans, providing care within a network of providers under a fixed budget to manage costs. It's designed to encourage cost effectiveness because the doctor's group keeps more of the capitation fee if they manage patient care efficiently. That is, fewer tests, timely preventive care. So I'll try and give you a practical example, but mind you, all these numbers are completely made up. The idea is the insurer pays me $100 per month for every adult between 18 and 35 years old who has that insurance in my practice. So I have 50 patients who meet that criteria, and so I make $5,000 a month from that insurer for that age group. The best outcome for me is that all of those patients are very healthy, none of them want to see me, and then I keep the whole $5,000. The worst outcome is that they're all very ill and require a lot of tests and procedures because the more money spent on services, the less saved as profit. Critics of this model raise a concern about undertreatment. If a physician group gets a fixed sum per patient, the group might be reluctant to refer patients for expensive procedures. Now, this feels unlikely. Most physicians are terrified of getting sued. So, in addition to genuinely wanting to do right by their patients, I can't see a world in which many physicians would deliberately compromise care in a way that could harm their ability to practice medicine in the future. There was also a worry about care delay or care denials, i.e., practices being unwilling to take on high-risk patients who might utilize a large amount of care and therefore limit their profits. I couldn't actually find hard data on how much this was actually happening, so it's unclear to me if this was a theoretical fear or something that was pretty prominent. Listeners, if you have any personal stories or anecdotes about this, let me know. One notable feature of the capitation model is that it can actually combine with other model types. In large health systems, the insurer pays the hospital, not the physician. So while a hospital might be under capitation, it could still choose to pay its physicians by salary. In small practices, however, how the insurer chooses to pay is equivalent to how the physician gets paid. Capitation gets much, much more complicated than this, but we'll leave it here today as the big picture. Now, the last model we'll address today is the value-based or quality-based compensation structure. These are often championed as the future of healthcare, pushed forward by the Center for Medicare and Medicaid Services, also called CMS, and many private insurers. In a value-based model, physicians and healthcare organizations receive bonuses and sometimes face penalties based on patient outcomes. For instance, how well patients with diabetes are managing their blood sugar, or whether readmission rates for heart failure patients go down. The idea is that aligning payment with quality of care hopefully encourages physicians to help patients stay healthy and not just treat them after they're sick. Now, this has some obvious drawbacks. Measuring value can be tricky. Are we truly measuring outcomes or just checking boxes? And if patients have complex social or economic challenges, doctors could be unfairly penalized if their outcomes don't improve quickly. Additionally, there are a lot of complaints that this model generates a lot of administrative overhead, given that hospitals will be responsible for tracking all of these outcome measures and reporting them to the insurance companies in order to receive regular compensation. That being said, value-based care has a lot of promise, and the rise of AI utilization might reduce some of that overhead burden. As of now, this is not a particularly common compensation model, but it might soon be coming to a hospital near you. So, a very quick summary before we talk about advocacy around compensation. Number one, the fee-for-service model. Physicians get paid by the service, but there's concern for possible overtreatment. Number two, the salary model. Physicians have a fixed annual income, but there is concern for underproductivity. Number three, the capitation model. Physicians or hospitals are paid a fixed sum per patient, but there is concern for undertreatment. And number four, value-based. Physicians are paid based on patient outcomes, but there are concerns about how to appropriately define value or high-quality care. So at this point, you might be thinking, this system is a mess. What's being done about that? And a lot of different stakeholders have different ideas about where we should go from here. Because CMS, and that's the government insurer that sponsors Medicaid and Medicare, is the largest insurer in the country, CMS payment policies often dictate what private insurers do. So how Medicare and Medicaid choose to reimburse is really important. Under the Biden administration, there were attempts to expand value-based care through the programs like the Medicare Shared Savings Program, which was established with the Affordable Care Act. However, the future of the program remains unclear given significant cuts to CMS in recent months. On the state level, some states are experimenting with global budgets for hospitals, essentially capping the total revenue a hospital can earn. At the local level, organizations like the PNHP, the Physicians for a National Health Program, and even smaller grassroots group advocates are advocating for change in the compensation schema. Right now, procedures like surgeries and interventions are much more highly reimbursed than preventive care and mental health care. These organizations suggest things such as boosting primary care salaries and increasing reimbursement on preventive services because, as the saying goes, an ounce of prevention is worth a pound of cure. So, we've touched on some of the various forces organizing around this topic, from the White House down to the local community health clinic. But what can you do in terms of advocating for yourself? Well, first off, you can ask your provider directly if they are a salaried employee or working under a different compensation model. As long as you're not requesting specific numbers, a clinician shouldn't have any problems being transparent about their compensation model. In fact, asking questions is one of the best ways to advocate for yourself in general. Here are some example scenarios and questions. For example, if you're recommended multiple tests for a workup, you can ask, how will these results actually change my treatment? Ask it for each test, as this question can reveal which tests are truly necessary. If a physician seems reluctant to refer you for a specialized test or scan, you might ask, is there a reason that we're holding off? And that can be followed up by, what would need to happen before you felt comfortable ordering this procedure? If you notice your PCP takes a long time to respond to messages, or is frequently rushed in their appointments, you might ask them about their panel size. Panel size is how many active patients do they have. Panel sizes between 1,500 and 2,500 patients are typical for primary care providers. If your provider has a panel size of 5,000 patients, that might be fine if you're young and healthy and just need your annual screening exams. But if your care is more complex, you might consider transitioning to a provider with fewer patients if possible. These are just a couple of examples of questions you can ask your provider to advocate for yourself in terms of where your money is actually going when tests are being ordered and when services are being utilized. Remember, you have the right to understand your healthcare, and part of that is grasping the structural incentives that might shape the care you receive. Thank you for joining me for this deep dive into physician compensation. Today, we've explored various compensation models and how each can shape the doctor-patient relationship. We've talked about perverse incentives, current policy debates, and what you as a patient can do to advocate for yourself in the doctor's office. If you enjoyed this episode, please share it with friends or family members who could benefit from a better understanding of physician compensation. And if you have any questions, comments, or ideas for future episodes, reach out on our website, acuteenchronicpod.com. Or, if you're watching on YouTube, drop them in the comments. Stay tuned. Next week, we'll be talking about emergency rooms. I'm your host, Dr. Olivia Rivera. Until next time, may your journey through the healthcare landscape be informed and empowered.